Okay, please start, gentlemen.
Okay.
Good evening, guys. Welcome to the CCC Radiology session live on YouTube. We have been teaching surgery, trying to pass out surgical wisdom to our postgraduate students, but this session is slightly different. It's almost like practicing surgery. And what we are going to do basically is that we did a session on radiology where the input was we covered too much in too short a period of time. So what we are doing this time is we are addressing HPB radiology for a start. I mean, for people, for postgraduates and for people who've started off practice, it is important because you have a lot of issues and sometimes you don't have a radiologist at hand. So to address the point, we have Dr. Ramanuj Mukherjee, who's going to start off the discussion. Me, I'm a surgical gastroenterologist, and we have Dr. Avik Bhattacharya here, the radiologist. So we have a radiologist at hand, and that's one of the best things to do, because I've always found that it's sensible to discuss, sit down and discuss with the radiologist over a table. So without further ado, we will start off, but we intend breaking the HPB radiology into 3 segments where we are going to go a fair bit into the details. So we'll start off with the extrahepatic biliary tract for a start. After this, we'll go into the pancreas, and then we'll go to the liver so that we don't leave anything begging. So feel free to ask your questions. We'll pick up your questions and address them. We've got a lot of us faculty members out here who we hope to address your queries as well. So Dr. Mukherjee, can you start sharing your screen, please?
Okay. Thank you, Dr. Bakshi. So, ladies and gentlemen, a very good evening, or a very good afternoon. Now, this session that Dr. Bakshi told you was an interesting session, and the 3 of us planned that, well, it's evening time in this part of the world, and well, in this winter, it's good enough to have a cup of coffee. And Dr. Bakshi and I were having a coffee, and Dr. Bhattacharya just joined in with the coffee. And we thought that the 3 of us, that, well, when the 3 surgeons joined in, because Dr. Avik is part surgeon and a part radiologist, he has been a long time associate with us. And so we thought that we will be naming our session as the coffee with the radiologist. And today, ladies and gentlemen, the main emphasis is something that is the bread, butter, whatever you call it as, is that the imaging of the biliary tree. And definitely don't get worried that we are not going to cover each and everything that comes under the biliary tree imaging. But the main emphasis is, if you are a practicing surgeon in a peripheral hospital to the most sophisticated hospitals, but deal with cases that pertain to the gallbladder, the bile duct, particularly the extrahepatic biliary tract, that includes the cystic duct and the common hepatic duct with the bile duct. Well, ladies and gentlemen, this discussion is for you, because the next 1.5 hours, we are going to take you as surgeons with expert opinion from Dr. Bakshi, who is a gastrointestinal surgeon, and Dr. Bhattacharya, who is going to be the radiologist in question. And I hope you have your cup of coffee ready. And then let us start with the discussion, ladies and gentlemen. So with this, as we have mentioned, we start with biliary radiology, and all of you must have had your share of understanding, well, not exactly so understanding about an ultrasound scan. Now, the first thing that we have on an ultrasound, rather than talk about the radiology jargon, is that because we surgeons are interested in understanding the patient and the image, and then when we can take the patient to the theater for an operation. Well, this picture is a very common encounter that you may have had even today if you have done a cholecystectomy, or maybe doing tomorrow as in cholecystectomy. Now, with this picture in concern, I would like to start asking Dr. Bakshi, because again, as I've said, we are both surgeons. I'm a professor in general surgery, and Dr. Bakshi is a surgical gastroenterologist. Now, Dr. Bakshi, to start with, sir, in your evaluation of a patient with a symptomatic gallstones, Okay, what are the exact points that you want your radiologist to comment upon when you order for an ultrasound scan?
Well, that's an important question. What I would like to hear about from my radiologist is whether there are any stones. For a start, there has to have to be stones. See, one of the problems, and I think Dr. Avik Bhattacharya would actually tell us about this, you have to realize that the ultrasound throws off acoustic shadows behind any echo opaque structures. Now, the eco-opaque structures can be stones, but they can also be the duodenal cap. You know, the duodenal cap containing air. Air is eco-opaque, and I'm sure Dr. Avik Bhattacharya is going to bear that out, which is why you will find the radiologist turning the patient from side to side. You see, the Hartmann spout actually often sits, or even the fundus sits very close to the duodenum. Now, if there is a fair bit of gas in the duodenum, you do get an acoustic shadow behind that. And I think Dr. Avik Bhattacharya will tell you the whole purpose of moving around patients is to move that duodenal gas shadow, if there is any, around, so that you have unquestionably an echogenic lesion and an acoustic shadow behind it. You can see these acoustic the acoustic shadows that go behind the stone. So that is the first thing. The second thing that I would like my radiologist to tell me is what is the size of the wall. And when the size of the wall is being discussed, I'd like to know whether it's symmetrical or asymmetrical. See, the gallbladder wall has two aspects. One is the serosal, one is towards the liver. The point that Dr. Ramanuj Mukherjee is drawing out for you is the hepatic side of the gallbladder. Now, if that gallbladder has acute inflammation, you have a thin rim of fluid, which is lighter in color, around not just the serosal aspect, but also the hepatic aspect of the gallbladder, which means there's an eco-lucent area on top and below. Also, I need to know from my radiologist that when the thickening is there, whether it's symmetric or asymmetric thickening. The moment you have an asymmetric thickening, you start getting worried. Are we treating with something which is not only an acute inflammation? So you think about it, guys, if you have a sac which is uniformly inflamed, that inflammation should be universal. So you would have the same sort of thickening on the liver aspect and the same sort of thickening on the serosal aspect, because the whole gallbladder is a single cavity. But woe betide if you find that one wall is thinner and the other wall is thicker, because immediately that happens, then you start thinking, could this be actually something else? Could this be slightly more sinister? And when we talk of sinister, we are talking of either mitotic lesion or even xanthogrammatic cholecystitis. So that's my second issue. The other issue that I would like to know is the aspect of what is the size of the bile duct. And often we find reports, common duct normal. Now I'd like to know the size. And normally what happens is Dr. Avik Bhattacharya, for example, always mentions the size. And the important thing is that there are two tubes which go behind. One is the common bile duct, and immediately behind is the portal vein. It's like a double-barrel rifle, except that the lumen of one of these barrels is far thinner than the other, because the portal vein should be bigger than the bile duct. If the bile duct lumen is as thick or even wider than the portal vein, then you might have a problem with obstructive jaundice. So that is something that you need to think about.
Okay.
Yes. Yeah.
Okay. So now, Dr. Bakshi, now to summarize, sir, that means that when a surgeon is looking at this picture, the first thing that he is asking himself is that is this a stone? I think that's a very simple one, given that we have an acoustic shadow to account for that, and acoustic shadows will indicate that this is the stone, which is more or less a very sitting diagnosis that can be done. And I think that everyone in the audience can very quickly identify that these things that have been shadowed by this are something called acoustic shadows. Okay, now, sir, the second point that they should be knowing is, or everyone should be knowing, is attention to the gallbladder wall thickness, as you have very rightly said, with an acute cholecystitis, because we will be talking about acute cholecystitis very quickly. We have one such patient with us. Then the third is the presence of an Hartmann's pouch and the bile duct. So let us hear what Dr. Bhattacharya has to come in. Let us hear what radiologist has to say or see when a surgeon refers a patient to him. Yes, do we have Dr. Avik with us? Hello.
Yeah, good evening, everyone. I'm
Okay.
Avik Bhattacharya. So it is going to be a very interesting discussion, as Ramanuj and Sir said very correctly. What is the surgical need? What is the surgical questions you are asking when you are going pre-operative in a situation of lap cholecystectomy? You want me to tell you if there is a stone inside the gallbladder is present or not, number one, and how many stones are there, what is the average size of the stone, and then see, sometimes when we see a single echogenic lesion, probably at the neck region of gallbladder, we always turn the patient to the left lateral decubitus to see the mobility of the echogenic lesion. Sometimes some echogenic polyp can also present like a stone. So they are
Yes, so
non.
Avik, I was coming to that exactly. So this is the point that I was coming to. So for example, well, I like drawing pictures like lot. Say there is a polyp on one wall, or I will draw the picture else on this one. Say there is a polyp on this side, and there is a stone by the side. Now, how do you guys differentiate between a polyp and a stone?
All right. So number one, as I told, the polyp will not move. The stone is mobile. But sometimes some stones can be adherent to the wall. That is fine.
Mm-hmm.
If it is a hard stone, it is
Mm-hmm.
echogenic lesion which will give you posterior acoustic shadow. That means
Mm-hmm.
posteriorly it would be black, as it is seen here exactly. See, on the opposite side, when a lesion, echogenic lesion in liver containing fluid inside it or blood inside it, it will give posterior acoustic enhancement. That means if a small hemangioma, which is echogenic, which is a small round echogenic lesion in the liver, it will give a posterior acoustic enhancement. Means it will be the posterior part of the hemangioma will be bright. Or if it is a clear gallbladder is having fluid inside it, that's why just posterior to the gallbladder, it will be a bright shadow. So it is called acoustic enhancement. And stone, it is a hard structure, it will give posterior black shadow, it is called posterior acoustic shadow. And here it is actually not a hard structure, it will give a reverberation artifact. It is not exactly a black artifact, it is bright black mixture. So these three are different: posterior acoustic shadow, posterior acoustic enhancement, and reverberation artifact for the air bubbles inside the duodenal bulb. But definitely, as I
Mm-hmm.
told, sometimes it is very difficult when the gallbladder is not properly distended, it is partially distended, and duodenal cap is very close to it. So sometimes the fundal region of gallbladder is very difficult to visualize properly. If it is folded, if it is again going in just
Okay,
abutting
okay, okay, okay. Avik, just a second. Yeah. You see, there is a question now. Both of us are surgeons, and we have had our fair experiences of duodenum or the colon being stuck on with the gallbladder. Can an ultrasound predict whether that if this is the gallbladder, then as a surgeon, we always have a curiosity whether the duodenum or the colon is very near, so that our operative plan may change. You may need to call in a senior colleague with you. Can we understand or predict this with an ultrasound?
Yes, we can. See, first of all, even see, ultrasonography is not a good modality to see bowel, but still,
Mm-hmm.
you see, if you look very carefully, you can see the wall of the large bowel, you can see the tree, it is incomplete, and large bowel has got its definite path, like ascending colon is continuous with the hepatic flexure, and then it's going as a transverse colon. And if you follow the gastric antrum, then you can see the first part and second part of duodenum is abutting the pancreatic head, and it is going down. You may not see the third part or fourth part very clearly, but second part of duodenum, its texture, its wall, it is pretty different to the texture of the hepatic flexure of colon. So I don't think it will be very difficult to differentiate between these two. Number one. Number two, as I was telling, the air would give the reverberation artifact, which is exactly not the same as the posterior acoustic shadow or black artifact. Okay.
Can I
Okay.
come in? I have two questions
Yeah,
for
please.
Dr. Avik Bhattacharya. Avik, two questions. Sometimes you have a contracted gallbladder, a contracted gallbladder, and the patient has had an ultrasound scan of the whole abdomen. And I sometimes find some of these people, if you actually do a complete fasting, when you do an ultrasound scan of the whole abdomen, the patient usually comes in having had a fair amount of water. Normally, water shouldn't cause a gallbladder contraction. But sometimes, just sometimes, I find that if you do an ultrasound scan on an empty stomach, it sort of visualizes the gallbladder better. Is that wrong on a surgeon to think that?
So this is absolutely right, because if you're absolutely fasting and you are taking good amount of fluid, your stomach is filled with water. I think that is the best part to visualize the gallbladder.
Okay.
Okay.
Okay. The second question is, sometimes you have people coming in with asymptomatic stones, and they said, is my gallbladder disease? You see, in the days of old, where we had oral cholecystogram, you give the patient a fatty meal and you watch the gallbladder contract. Is there any way that can be also recreated in an ultrasound scan rather than having to go through to a radioisotope scan of the gallbladder?
So we can do that. Sometimes,
That means, Avik, yeah. That means basically, you see, we are coming on to the concept of something called as the ejection fraction of a gallbladder. Because in this question, what Dr. Bakshi told was a very, very relevant question. Because if these are asymptomatic stone, the patient doesn't have any symptoms, did an ultrasound, say, for example, as an executive checkup, and then that did pick up with the normal wall thickness, these 4 stones. So can you say about the ejection fraction that happens?
actually, it is done very infrequently, but I have done few cases where there is a small stone. Otherwise, it is asymptomatic, a vague pain. We are not sure whether it is due to that, whether this gallstone is symptomatic or patient is suffering from irritable bowel syndrome, IBS. That's totally different entity. So in that, sometimes we give a small cube of butter. We ask the patient to just take it, and after that, after around like 15 to 20 minutes, we recheck the gallbladder, and if it is really the gallbladder is contracting, it is the volume of the pre food, the pre butter gallbladder volume, and post it is significantly gallbladder has contracted, then it is functioning normally. Although
Okay.
last 5 years I have done 2 or 3 cases, 1 or 2 of probably Sarah sent me. So that is the whole idea.
I always ask very difficult questions of Avik. Sorry, Avik.
The whole idea is, if we can demonstrate the gallbladder is contracting, that means. So what do you think, sir?
Yes, because some people ask me, is my gallbladder functioning? I have a single stone. I want to wait. It's completely asymptomatic. The gallbladder wall is, perhaps the wall thickness is reasonably normal. So I'm a bit stuck. How do you find out whether this patient is actually has a gallbladder which is non-functional? So I think under that circumstance, I would ask for an ejection fraction, and then ask you to do that sort of a test to find out whether the gallbladder is contracting or not.
And sir, on ultrasonography, when we can do a fasting scan, and then we can ask the patient to take a normal meal, and then after like half an hour to 45 minutes, we can recheck the gallbladder to see the contract.
Right. Okay.
Ultrasonography is a very good modality to evaluate gallbladder, and part of the bile duct extra and intrahepatic bile ductal system. And as said told earlier, that double pipe, one is the CBD and one is the portal vein. To see the CBD, still I believe ultrasonography is it is much, I mean, it's not like for to see the CBD we need to do an MRI scan or MRCP. Ultrasonography is a pretty good modality to see the distal end of CBD itself. If the patient is having a proper bowel, fasting state, and he has got a proper bowel clearance, then we can see the CBD on ultrasonography as well.
Okay, I get your point, Avik. Avik, now see, this is okay. So that means that on his summary, ladies and gentlemen, you see, this is what exactly a surgeon thinks over, because rather than only seeing a plate and seeing there are 2 or 3 stones, please remember that all the points discussed are pretty important if you are a practicing surgeon doing gallbladder, because in the spectrum of the cases that you are going to get, think over whether these are stones. Number 2, think over with the wall thickness, the Hartmann's pouch, if it can be seen, and then, as Dr. Bhattacharya has said, the bile duct. And on this one, I will change gears a bit, and then I will take you to the emergency. And this is a patient with an acute cholecystitis, and as Dr. Bakshi was mentioning about an acute pericholecystic edema. Okay, and now I think that for the benefit of the audience, what I will do is that I will mark the edematous tissue by this color so that you can appreciate that this is the edematous tissue around, okay, which appears technically a little more black in contrast with the liver. Okay, Avik, just correct me if I am wrong. That means that if this is the gallbladder wall, okay, I think that I'm marking the gallbladder wall. Is this the edema fluid?
Yeah, actually, two things. We can see in a setting of acute cholecystitis, we can see a fluid collection, loculated fluid collection in pericholecystic region, in between in the pericholecystic liver bed as well as in the subhepatic region. We can see the fluid. Second thing, we can also see the seepage of fluid because of the acute obstruction. The seepage of bile we can demonstrate. I mean, across the gallbladder wall into the pericholecystic or in segment 5 or segment 4B of liver. In that case, ultrasonography is not a good modality to demonstrate the pericholecystic seepage of fluid. But yes, definitely, if it is a hypoechoic region, which is just abutting inflamed gallbladder, what does it mean? Inflamed gallbladder, it means it is a distended gallbladder. The wall thickness should be more than 3 millimeter, and the transverse diameter of the gallbladder should be around 4 centimeter or more. It is a distended gallbladder. We could see the sludge inside the gallbladder lumen, few calculi probably stuck in neck or cystic duct region.
Okay, just a second to interrupt. Okay, can you please tell me those criteria? Because yes, Dr. Bakshi, please.
Avik, 4 millimeters or centimeters?
The 4 centimeter is the transverse diameter of the gallbladder.
Oh, transverse.
Okay, right. So let me have these criteria clear out. Okay, that means you are trying to suggest that this transverse diameter should be, if this is A, it should be greater than 4 centimeters. I mean, that means okay. Number 2, what about anything about the thickness of the wall?
It should be more than 3 millimeter.
Okay, so B should be greater than 3 millimeter. Okay, right. Any more criterions? And definitely you have the pericholecystic edema.
Ultrasonography, you could rate this thing on book, but we always rely on the clinical setting. I think part of ultrasonography in a setting of acute cholecystitis to see the complications, whether there are multiloculated pericholecystic collection, and as such the wall thickening, whether the wall thickening is symmetric or asymmetric, whether there is air inside the gallbladder or inside the gallbladder wall, or is there any evidence of impending rupture, and the most important thing is the CBD, whether there is any stone slipped in the CBD lumen or not.
Okay. Well, just 2 points to make. You see, because this is another question to Dr. Bakshi also, sir. So important things are that a patient, if an acute cholecystitis, will present with a very tender upper abdomen, but the rare differential diagnosis that we do come across is a state of an acute hepatitis in many developing countries. It could have been a viral hepatitis also. Now, clinically, sometimes it becomes very difficult to distinguish because the patient is in pain. You don't get a very impressive history, and differentiating sometimes is dependent upon the radiological features. Okay, we'll start with Dr. Bakshi. Sir, any clinical things, or as a surgeon, how will you distinguish between these two?
Well, I've always been taught that if you have acute hepatitis, the patient is also equally tender over the costal margins. Whereas in acute cholecystitis, it's located to that particular area where the semi-lunar line crosses the lateral edge of the rectus abdominis, crosses the costal margin. And sometimes you even have a small bit of edema out here that goes by the eponymous name leaks, L-E-A-K-E, apostrophe S, leaks sign, sign. So inflammation, edema of that particular area where the the lateral margin of the right rectus abdominis crosses the costal margin. It is unusual to find tenderness if you go down behind the anterior axillary line in acute cholecystitis. You will find that if it's acute hepatitis. So that's one aspect. The entire liver along its complete length is tender, whereas in an acute cholecystitis, early on, it's located to one area. So that is a proviso. Once acute cholecystitis has gone on to a position of either localized rupture or increasing inflammation, that sign is unfortunately lost. So do you have anything else to contribute, Ramanuj?
No, I don't think so. Well, because what I have always felt is that because definitely acute hepatitis is associated with a prodon, which is very uncommon in an acute cholecystitis, but patients with a biliary colic will usually give you a history of a fatty food intolerance, bloating, but in an acute emergency or in an acute setting when the patient is screaming in pain, getting these histories are very difficult. So as you very rightly said that this, but I think that both of us will agree that an acute hepatitis with an acute pancreatitis does form a strong differential diagnosis with an acute cholecystitis. Believe me, theoretically, we may say that we may shrug away that no, these are different pathologies. Not exactly. In an emergency or in an emergency presentation, both of these are common encounters, and then we have to talk with our radiologist. Okay, so how do you distinguish between these two, and is there any confusion and overlap? Yes, Avik. Now, to start with.
Definitely, this is a very interesting question, and I would tell you there are some points. I have seen cases where there is a right upper quadrant pain, suspected acute cholecystitis. It came out to be acute hepatitis. So there are features which could differentiate between hepatitis versus acute cholecystitis situation. See, first of all, in a setting of hepatitis, as I said, patient would have a tender hepatomegaly. Liver will be enlarged, number one. And number two, this is very important point radiologically. You could see a thickened echogenic periportal soft tissue. This is very important, and we see this on our ultrasonography, even on CT scan also, on MRI also. We could see this thickened in ultrasonography. We call it echogenic. In CT scan we call it thickened hypodense, and on MRI we call it thickened hyperintense periportal soft tissue. There is a significant periportal soft tissue thickening in a setting of acute hepatitis. Number one.
Okay, sorry, my screen just got off. Just a minute.
Number two. Number two, gallbladder wall is edematous in a setting of acute hepatitis, but usually the gallbladder is contracted. We don't get a grossly distended gallbladder in a setting of acute hepatitis, although there is uniform wall edema in gallbladder in a setting of acute hepatitis. But most of the time I saw the gallbladders are partially distended or contracted in a setting of acute hepatitis. You could see the sludge inside the gallbladder. You may see incidentally one or two gallstone, but like in acute cholecystitis, you could see a tender, it is a tense gallbladder. You could see the distended gallbladder, thickened wall, turgid, a stone. Definitely you could see a stone is impacted either in neck region or cystic duct region. If you see it carefully, you could see sludge. Sludge can be seen in both the conditions. But this hepatomegaly, increased thickness of periportal soft tissue, increased echogenicity of periportal soft tissue, and edematous contracted gallbladder going in favor of acute hepatitis, whereas this tense turgid gallbladder with wall thickening and gallstone goes in favor of acute cholecystitis.
Okay, now again coming back to on this one, because we are surgeons. Okay, the important things are that this is one of the patients of an acute cholecystitis. Now we surgeons both want you to read this one because we are really confused about, because this strange thing doesn't look like a gallbladder. So we are both worried. Dr. Bakshi and I, we are really worried that, okay, so this doesn't look like a gallbladder. So what the hell is this one? Okay, Avik, so please read this thing for us.
First of all, I could see this is a gallbladder, which
okay.
has uniform wall thickness, wall thickening and wall edema. Significant wall edema is there, although the lumen is anechoic. A small amount of sludge I could see probably in the body region, and there is small pericholecystic fluid collection.
Okay, so
So
Avik, is this the pericholecystic fluid collection around?
I do think this is small, or it is a edematous gallbladder. It is a gallbladder edema, which is
Okay.
usually, and the fluid, again, the fluid is hypoequic on ultrasonography. So probably this is the pericholecystic collection. You could see some collection around the neck region as well, neck region of gallbladder. So it gallbladder with wall thickening and pericholecystic fluid collection.
Okay, right enough. Now to Dr. Bakshi.
I see
Sir,
this,
with the Tokyo guidelines being now in practice, and we more or less all general surgeons and gastrointestinal surgeons follow the Tokyo guidelines. Sir, if you are planning for, this is the Tokyo grade A, and if you are planning for a cholecystectomy before the operation, what are the things that you want to see from the report of a radiologist in this one?
I would actually like my radiologist. See, the problem is how safe is it going to be dissecting the gallbladder off the bile duct? So
absolutely. So
that
this
is
the
my critical bit when I'm operating on a patient with an empyema of the gallbladder, I mean, if you will. So the first warning I will have is probably a slightly raised or even quite bit raised of alkaline phosphatase and gamma GT, or even SGOT and SGPT. All their liver enzymes are mildly raised. So particularly if the patient, sometimes what happens is the patient has spent a fair bit of time reaching your services. So that is something I'd like to know. I'd like to know whether there's any, from my radiologist, whether there's any evidence of intrahepatic bile duct dilatation, which would mean that there's an impaction of the stone or the gallbladder or the peripolydocal inflammation carrying on from the gallbladder over to the bile duct. So in that situation, I might even ask my radiologist to be absolutely sure that there's no pressure on the bile duct. I would also pay great attention to the actual size, the thickening of the gallbladder wall. Whether it's, as Dr. Avik Bhattacharya quite rightly said, it should be less than 3 millimeters. Sometimes you have 6 millimeter plus bile duct, common bile duct, gallbladder wall. And there you can have a really tough gallbladder to do, particularly if you're planning for a laparoscopic cholecystectomy. And there you might have to plan for something that we do is a subtotal cholecystectomy. Dr. Mukherjee, we have some questions from here.
Okay.
What are the indications for a HIDA scan?
Sir, we'll definitely. So I will write these questions before I do forget. HIDA scan, definitely. I was intent on asking this. Okay.
And also signs of impending rupture of gallbladder on the ultrasound.
Definitely, all of these. Again, see, this is what, again, great minds think alike. Signs of an impending rupture. But before we go to this interesting question, I have more technical
issues. That's not my question. That's a question on YouTube by Dr. Anup. No, Dr. Sangeeta.
Okay, good one.
That's very good.
Good. Okay, now see. Okay, so the coffee is getting, so we need another cup of coffee now. In this one, to Avik and Dr. Bakshi, you see, for the last around 1.5 years, I have done an interesting project. And what I have done is that dependent upon, so when we had patients coming in for a laparoscopic cholecystectomy, so we used to do a pre-operative gallbladder wall thickness within 24 hours. And if someone had we used to see around that what was the difficulty score, what was the operation time with the thickness, and definitely more will be the thickness, definitely the more difficult it is. And we found that 5 millimeter is the critical thickness over which, if we give a course of antibiotics and did wait for 7 days, probably in that about 65% of the patients had their thickness reduced and it becomes an easy lap chole. The rest of the patients had either a conversion, and our rates of conversion were around 42%. That's pretty high. Okay, so that means, Dr. Bakshi, so to ask you, sir, I got in my series 5 millimeter as a cutoff point. Sir, in your series, at what point of an acute cholecystitis you say that no, this is not going to be a good laparoscopic cholecystectomy, let's wait, let's keep our fingers crossed, give an antibiotic?
See, there was an interesting paper from Italy where, what they assessed was how long did one particular surgeon, Surgeon A, take to do a gallbladder if it was 24 hours after an attack, 48 hours after an attack, 72 hours after an attack, and plus 72 hours. They found, you see, competence of doing cholecystectomy, and that's a common operation. Competence varies from surgeon to surgeon. So you can't say what is going to be your criteria for saying this is becoming a difficult cholecystectomy. So the Italian studies did something excellent. They followed each surgeon and gave him a certain time for doing a cholecystectomy. This was his duration. And they inevitably found that after post 72 hours, every surgeon, the duration of surgery became longer.
Okay.
So you see,
so
that is why
rather than thickness,
yes,
they did with time. Okay, that's an interesting one. You see, ladies and gentlemen, as you see this evening, the more we talk about gallbladder diseases, we forget everything in the world. Two surgeons talking around with gallbladder, well. And the next one is that, so if this is this, to Dr. Bakshi, sir, before we put on the patient or before we think about an operation, what are your plans about, do you like to do an MRCP in these cases, particularly as you have said, if there is a marginal elevation, say for example, the alphos is raised, the SGOT, SGPT is increased. So do you think that doing an MRCP does help? Because we'll be coming to Avik with this question.
I always have a simple rule. If I'm driving my car, I drive better if I have a map. So if I'm doing surgery, I always find it easier to drive around if go through surgery if I have a roadmap. So if I know that there's a narrowing at that area where the gallbladder is impinging on the bile duct, it's a junction between the common hepatic duct and the common bile duct, I will anticipate for a difficult cholecystectomy and perhaps even a subtotal cholecystectomy.
Okay, sir, a good point taken. Do you think that MRCP versus a CT, because MRCP, because we surgeons have a feeling that MRI is not that good with fluids, because acute cholecystitis is all about inflammation and fluids. At this point, do you think that CT is better than an MRCP in this one? Because my practice is to do a CT rather than an MR. Hence the reason about asking.
I will ask Avik, because with the modern generation machines, I think fluid is probably on a T2 weighted image better shown with an MRI rather than with a CT. But I'm willing to learn from Avik.
Okay, yes, Avik. So now you see two surgeons. I prefer a CT. Dr. Bakshi prefers an MRCP. Okay, so both of us are fighting.
Yeah,
you will have the final say.
If we are sure we are dealing with acute cholecystitis and there is some elevated alkaline phosphatase, that's why we need to see biliary tree properly. Then MRCP is the investigation of choice. Whether the edematous gallbladder is impinging on the ductal confluence or common hepatic duct, or compressing it, causing elevated alkaline phosphatase, or a small tiny calculus has slipped into the distal CBD causing obstruction, we need to differentiate. This is important, and for that we need to do an MRCP. And if we're not sure whether this pain in right upper quadrant is due to acute cholecystitis or something else, could it be some other funny thing?
Okay. Just on this point, a bad thought. Can it be an acute pancreatitis detected quickly on this imaging, MRI or MRCP?
See, in acute pancreatitis, in a setting of acute pancreatitis, in first 1 or 2 days, you may not see anything in either on MR or CT scan, right? So the first imaging modality for acute within first 24 hours, the imaging modality of choice for pancreatitis is ultrasonography, just to see the etiology, gallstone and any CBD stone present or not, whether we do an intervention ERCP to clear the stone or not. That is the first indication of imaging in acute pancreatitis. After 2 to 3 days, after 72 hours, there is a need for a cross-sectional imaging. Either, I mean, in that case, we definitely prefer the CT scan, contrast enhanced CT scan, to see the pancreatic necrosis, peripancreatic necrosis, the collections, and everything can be seen in one. It is a one-stop shop. Definitely, we have higher, like 128 slice CT scan. There are even higher generation CT scans where we can give you the equal sensitive images, or like the sensitivity of picking up a small stone in CBD would be as good at MRCP when we are dealing with a very high-end CT scan. That is fine, and it is a very quick procedure. For an unstable patient, always it is preferable. As Ramanuj said, in a setting of acute cholecystitis, if you go for a good quality CT scan, you would be having a overall idea of about the upper abdomen, what's going on there. But if you only interested in biliary tree, still MRCP scores higher than CT scan.
Okay, that means, so what is your take home for surgeons who are operating on an acute chole? Because I'll ask you and then I'll ask Dr. Bakshi again. Okay, so what is your take home? Should we routinely think about an MRCP if you show us an IGBR dilatation?
If the patient is having a asymptomatic gallstone or acute cholecystitis and alkaline phosphatase, and the LFT is normal, we don't do anything. We, go for surgery. Like my institute and the sir also, Dr. Devaksh also followed the same thing. If the LFT is normal, acute cholecystitis diagnosed on ultrasonography, clinically acute cholecystitis, go for surgery. If the alpha or LFT is deranged, then if a good ultrasonography scan could not find any stone, better to go for an MRCP. For it has got some medical legal implication as well, and then we can go for the surgery.
Okay.
Yes, I would agree. I would completely agree with Dr. Avik Bhattacharya. Ramanuj, I think we need to address the questions as well. What's the indication for a HIDA scan? These are the YouTube questions.
Okay. We are coming to that. Now, coming on to the question to Avik particularly. Avik, see, we are both surgeons, and definitely we have had our share of a gallbladder perforation. Either it can be an empyema which has perforated at the fundus or the body. And believe me, gallbladder perforations are bad diseases. Okay. On an ultrasound, can you detect any perforation in the gallbladder?
Or an impending perforation.
Yeah.
Or an impending perforation.
Perforation can be seen very clearly. There will be a breach in continuity of the gallbladder wall. You could see there is a breach, and you could see a pericholecystic collection adjacent to it. So that is a clear-cut finding of ruptured gallbladder with pericholecystic collection. The point is the sign of impending rupture. In that case, we should see the wall thickness. If it is a uniformly thickened wall, and in some place you could see the wall thickness is significantly reduced, there is it is a distended gallbladder, and in a portion you could see the thinned out a small portion of gallbladder wall. You could suggest this is probably the area where it could rupture. So this is a sign of impending rupture.
Okay. Avik, does adding a Doppler help in any way?
In finding the impending rupture?
Yes.
I don't have any idea. I have to go through the literature.
Okay, no, because we are thinking about that, because again the vascularity may have been
there
bad.
Are
okay.
other questions. Some of the questions.
The next is
Ramanuj.
Next is
can we?
Yes. Yeah, please.
There's some other questions. Signs to suspect a cholecystoenteric fistula.
Exactly. I was going to come to these two, Avik, because the cholecystoduodenal and cholecystocolic fistulas are not that rare, because we have a long experience about dealing them, and they are all surprises. So rather than getting surprised, can you have an idea about is there any cholecystocolic or cholecystoduodenal fistula?
Ultrasonography.
Then we come to the next question. Yes, on an ultrasound.
On ultrasonography or any other cross section, we could see the cholecystoenteric fistula very well. First of all, in a setting of like symptomatic gallstone, if we do an ultrasonography, we don't see anything inside the gallbladder lumen, only air. And if you see the pneumobilia, whereas where there is no history of previous instrumentation, and you could see the CBD is pretty well, reasonably well, but you could see the biliary radicals are filled with small air bubbles, that is pneumobilia, as well as irregularly thickened, partially contracted gallbladder having multiple air bubbles inside. And then
Okay, we just sorry to again barge in. If you get to see an air bubble inside the gallbladder, because see, we surgeons want to have something, when you, whatever you see, we believe. Do you think that you will suggest the patient for a CT scan?
yeah, we will, because see, air forming organisms like emphysematous cholecystitis can also cause air inside the wall of gallbladder or inside the lumen, right? But
Exactly.
here in a setting of and see, in a cholecystoenteric fistula, the clinical features would be very catchy, because patient would have a pain in right upper quadrant. Suddenly patient would probably will present with the ileus or something like that, intestinal obstruction. You do an ultrasonography if suppose that stone is causing somewhere obstruction. So I have seen one or two cases where the stone stuck in the terminal ileum. It's a big stone. Usually the fistula are,
We have one such case. That's a dream case. But for majority of us, both Bakshi and I, we have had experiences of a small cholecystoduodenal. Okay, the stone didn't get a chance to go through, but due to the inflammation, they went in. Okay, so that means only air could enter the gallbladder and the biliary tree. Okay, in those cases, yes.
to do a cross-sectional imaging, preferably CT scan, to look for
Mm-hmm.
the enteric, where the fistula is located, and
Okay, right.
fistula, it could be a cholecystoduodenal fistula, so we need to locate it properly.
Very
So,
good. Thank
Avik,
you.
can I just suggest that if you find air inside the bile in the gallbladder, would it be sensible to follow it up with a CT scan? Or, what do you think?
That's why I'm saying we need to go for a CT scan, a proper cross-sectional imaging, to see it in multi reformatted images could give us a good view whether the fistula is in between the gallbladder and duodenum, or the CBD or duodenum, where exactly fistula is situated and where the stone is going, like after the fistula, if at all it is going to the
Okay, right.
Okay,
So
great.
that's a very nice learning experience for me also. That means that you need to talk to your radiologist, that not only which organ is involved, but also maybe because at these cases they are very difficult to do laparoscopically. We have had surgeons who have injured the colon thinking that was a gallbladder. I think Dr. Bakshi will absolutely agree with me that these are
Yeah,
absolutely very
except
difficult.
that I remember that on one patient who was very well known to our faculty members, she came in with gas inside the gallbladder, and Dr. Avik Bhattacharya actually asked for a CT scan. We did diagnose that she had a cholecystocolic fistula, and we did it successfully laparoscopically by using a GIA stapler across the fundus of the stuck fundus of the gallbladder.
Okay, that's
Uh,
very nice. So that
so
is the
that was
reason, ladies
where
and
Dr. Avik
gentlemen,
Bhattacharya bailed us out.
right. So that is the reason we are having this discussion on a coffee table, ladies and gentlemen, so that when you get such patients of an acute cholecystitis or a bad gallbladder, please talk to your radiologist in that. Avik, we have a
Okay,
question on
will be a
HIDA
big
scan.
Ramanuj, yeah.
Yeah,
Once you finish that HIDA scan, two other questions I'd
right.
like you to approach. Can we
Okay,
decide
good one.
whether the operation is possible based on ultrasound findings? Number two is something you and I will handle if you're not being able to achieve the critical view of safety due to a frozen scallops. How will you proceed? That is would be addressed by you and me. And when to
Mhm.
go for a cholecystectomy in relation to gallstone size and gallbladder wall thickness. So
Okay. So the first one, Avik. Avik, number one is that
yeah,
HIDA scan.
yeah.
When do this? Why do this?
Is nowadays the nuclear medicine guys does all these things. We don't do that. So it is a
Okay.
cholecystectomy or a hepatobiliary scintigraphy. It is we give a tracer in the veins, and that tracer, I think tracer should it is excreted through the the liver parenchyma inside the biliary ducts, and then it gets collected in the gallbladder. And to see the functionality of the gallbladder, we do this HIDA scan. We used to do these scans. I don't know the utility of HIDA scan nowadays. Probably Sir would
can
tell us how frequently he would ask for a HIDA scan for
can
a
I can I just come in for a
Yeah,
little
please.
while? Away.
Yeah.
Well, I'll tell you when I ask for a HIDA scan, when I have this executive health check up person coming in and saying, okay, so I have gallstones incidentally diagnosed. Is my gallbladder functional or not? So I ask for a HIDA scan because inevitably what they do is they actually document the ejection fraction. So that's number one. Number two, and that was something that was pointed out by a very senior medical gastroenterologist, one of the professors, Dr. Professor D.N. Guha, he pointed out that, because they were used to the scintigraphy, he said, you can actually see whether there is bile reflux into the stomach. So if the dye, the scintigraphic dye goes into the stomach, that patient has biliary reflux gastritis. And I followed up all my scans after that, and that is remarkable,
Right. I think that, okay, Dr. Bakshi, just one point to make, you see, in an acute, HIDA scans are particularly were popular in an era where ultrasounds were not that popular and CT scans were just too young to be in practice.
Yes.
Now, in the era in which ultrasound or a bedside ultrasound is the dictum, an acute calculus cholecystitis is a very standard case that more or less every surgeon will see very often. An acute calculus cholecystitis is a much rare entity in an intensive care setup, which again becomes a very difficult thing to diagnose. But thanks to the bedside ultrasound, if we get, like, say, our experiences of an acute calculus cholecystitis has been very few, only 3 cases over these many years. And that also to diagnose an acute calculus cholecystitis in a patient with multiple other coexisting medical and surgical problems becomes a nightmare. Even if these patients are stable, believe me, you will not like to take the patient to a nuclear medicine to have an HIDA scan, and ultrasound does a good job to diagnose. Probably another thing that which I have found a HIDA scan that is very useful is that when I've done an hepaticojejunostomy and I want to see the patency of the tube and the amount of the holdup of the contrast and the dye, it is that those times, well, a redo stricture surgery, I feel that probably 1 year down, I would like to have a HIDA.
I agree completely. Acalculous cholecystitis is that you need a medico-legal documentation for saying this is a non-functional gallbladder. Absolutely.
Okay, right. So I think that, okay, the next 2 questions, I think that are surgical questions, Dr. Bakshi. Number 1 is that what if we cannot have a critical view?
Well, if I can't have a critical view, I will not damage the bile duct. So I would opt for a subtotal cholecystectomy. And we've got our own particular series of about 12 laparoscopic subtotal cholecystectomy. The only issue being that you have to ensure that the stump you're leaving back, it does not contain any stones. So that is far easier to do when you're doing it open, but it requires a bit of manipulation and action with the suction and the water jet to ensure that all the stones are taken out from the stump that you're leaving behind. That's number 1. Number 2, if the mucosa of the stump looks suspicious, then you have to, if you have facilities for frozen section, please do a frozen section, because one of the problems of a frozen callus is also a mitotic lesion at the neck of the gallbladder. So
I think that's a point well made. Just one point to add, because because surgeons are in their various tiers of training and with experience and expertise. If you have a frozen callus and you are not being able to do a critical view, please think of a conversion in that case so that you can see the anatomy better. If you, as Dr. Bakshi has very, very appropriately said, your procedure in that case is to do a subtotal cholecystectomy. But remember, doing a laparoscopic subtotal cholecystectomy requires you to be very proficient in an endosuturing, or because staplers to be applied down there are very difficult to be done. A number of staplers are not available in that arena to be used. And to do a posterior dissection in the body with a sucker, with an inflamed gallbladder wall, to stitch that and to take the residual stone from the cystic duct stump out. Believe me, ladies and gentlemen, until and unless you are trained and you have an experience in doing that, it is much safer to do the same procedure in an open, put a drain, and always put a drain. In a routine laparoscopic cholecystectomy, I will not put a drain. In a subtotal, I will put a drain. And that is what is my opinion.
Yes, I think just to document that I attempted my first laparoscopic subtotal cholecystectomy after 6 years of doing cholecystectomies. So
I think that's a very
fair bit of time to
wise
evolve
answer.
into that.
Right. And I think the
And I
last
don't
question
consider
was
it a detriment. I think patient safety is important. Now,
definitely.
Ramanuj, also, what is the difference between a subtotal and a partial cholecystectomy?
Again, for surgeons, again, so you see, terminologies do evolve. There is no particular international consensus that I know that has evolved into that. What has come around is that there are two forms that if you are doing, I think everyone can see the screen. If this is the standard cholecystectomy or laparoscopic cholecystectomy, where you are going to clip the cystic duct, a subtotal cholecystectomy, people have called it as type 1 and a type 2, is that in which if you leave one part of the stump, that is called as a type 2, in which you leave a part of the infundibulum, particularly the part of the Hartmann's pouch, and the cystic duct is not well seen, and this is technically called as a type 2. A type 1 was described as in which that you could take the cystic duct, but the posterior wall of the gallbladder was adherent to the liver bed, and due to some pathology, say for example an empyema gallbladder, this is an or when a or a cirrhotic liver,
Or a cirrhotic liver, yes.
yes, so this becomes a very difficult thing for to take out the gallbladder, because the liver bed is bleeding like hell. So in these cases, what we do is that we retain the posterior wall, and this was called as a type 1 cholecystectomy. Some people called it, and now the term partial cholecystectomy was a very confusing term, whether it is a type 1 subtotal or a type 2, and hence people evolved with these two techniques. Okay, Dr. Bakshi, please. Sir, any modifications or?
No, it is my impression that the type 1 has been often called a partial cholecystectomy. I might be wrong, but just check it up, chaps. This was asked by Dr. Ravi Bhushan Jha. Just check it up. But my impression is that, as Dr. Ramanuj Mukherjee is drawing out for you on the screen, for me, a TP1 is a partial.
Right. Okay.
How will you, there's also a question, how will you manage a patient with acute cholecystitis with pancreatitis, raised alphas, gamma, GT amylase, and lipase? When will you perform lap poly in this patient? I think I will heavily depend on Avik to bail me out on this one. Shall we discuss the bile duct and then go to that?
Right. I think that brings us to the question, Avik, that of an ultrasound, when do you suspect a stone in the bile duct? Because this question has been a very apt question at the very appropriate time. At what point do you really think is there is a stone in the bile duct? Because we surgeons, definitely we are always fearful of two tubes. You know, Avik, one is the urethra and one is the bile duct. Believe me, as surgeons, life has taught us that always. God has given two lungs, two lobes of the brain, two kidneys, one bile duct. And we are always very afraid. Okay, so when do you suspect a stone in the bile duct?
So, so anywhere in in our body, a stone will be echogenic, and it will give a posterior acoustic shadow. Only few sometimes in gallbladder, when we see large ball or soft, we call them soft calculus, where we see a echogenic lesion which is mobile, but it is not giving a posterior acoustic shadow. We call it is either soft calculus, it's forming calculus, or it is a sludge ball. Apart from that, any renal calculus, uretary calculus, CBD calculus should give it should be a round to oval echogenic lesion that would give a posterior acoustic shadow. When we see on ultrasonography of upper abdomen, we first see the liver. In our this is the dictum. We see the liver properly, carefully, and if we see HBRs are dilated, intrahepatic biliary radicals are dilated, even if it is a minimal central dilatation of the intrahepatic biliary radicals, we just start suggesting probably there is some obstruction downstream. So we see gallbladder, and if it is a grossly distended gallbladder and nothing inside it, then probably according to the Kurvars's law, we start thinking of something bad is stuck in the distal CBD or somewhere. And if the gallbladder is also chronic cholecystitic gallbladder, irregular wall thickening is there, few calculi are there inside the gallbladder lumen, then we think probably there's something should be there in the CBD, because IHBRs are dilated. We see CBD very carefully. Sometimes because of the duodenal air artifact, the distal CBD is very difficult to visualize on ultrasonography. We ask the patient to drink water on table. So in that way, if the water comes without, there will be some air bubbles inside the water, but still, if water filled the first and second part of duodenum, the visualization of the intra-pancreatic part of CBD or distal CBD is more clear. And in that CBD, if we see a similar looking echogenic lesion, which is giving post-acoustic shadow, we are pretty sure we are dealing with a calculus inside the CBD. See, nowadays we have Doppler study. So even if there are two pipes, we just give a Doppler pulse, and then the portal vein would have a blood flow inside, hepatopetal blood flow. The hepatic artery would have a hepatopetal blood flow, and the CBD would have no blood flow, no flow inside. So that is CBD. And if we could see some echogenic lesion inside the CBD, we are sure we are dealing with a choledocholithiasis.
Okay, Avik, just a point to add immediately, because this patient, as this question has come from the YouTube, can you see the pancreas? Because in this setting, you said that it was very difficult to look into distal stones. Do you think that you can diagnose pancreatitis? Because we are not talking pancreas today, I know that. But still, because acute cholecystitis with pancreatitis, are you confident in diagnosis of pancreatitis if you did not know the liposomal report radiologically?
Radiologically, sometimes if it is a very mild pancreatitis, you might not have any morphological change in pancreas. You on CT scan, you would only see some streaky peripancreatic densities. Pancreas is more or less normal in size. In that case, it is very difficult to diagnose pancreatitis on ultrasonography, because the morphology of pancreas would be almost normal, but patient would definitely have probe tenderness over pancreas, number one. And if it is a edematous pancreas, then we could definitely see it is a bulky edematous pancreas which is hypoequic, which is compressing the pancreatic duct. The peripancreatic fat would be more echogenic, and in duration will be there. So all these features goes in favor of acute pancreatitis, even if there is no peripancreatic collection. But seeing a hypoequic pancreas, compression of the, you cannot see the pancreatic duct properly, and more echogenic and nodular peripancreatic fat, those things goes in favor of acute pancreatitis.
Right. Now, because
so if you have Ramanuj, if you have, and you were asked what would you do if the alphas, gamma GT, amylase, lipase were all raised, I would, my warning signals, my warning antenna would go up immediately. I would step back before I rushed in for that particular cholecystectomy, isn't it? Would you do an MRCP then?
Exactly. This is what I was going to ask Avik. Avik, see, at this point, because we should, Dr. Bakshi and I, we have all surgeons think alike. Now we are both worried that now at this point, you see, that means both of us are thinking that there is a stone probably that is impacted in the common channel. Dr. Bakshi, am I right, I think, on this point?
Absolutely. Yep, sure.
Okay. There is a stone in this point. Now, we surgeons are now stuck. Whether should we go in for an MRCP, should we go for MRI of abdomen, or should we go for a CT scan of the abdomen? Which one do you think? Or should you have a new gadget and endoscopy? I give you an MCQ a week.
Yeah.
Okay.
I think
okay, right.
Two right options. One is the MRCP and other is the endoscopic ultrasonography. But MRCP being the invasive, I would prefer MRCP over the endoscopic ultrasonography, because it is a non-invasive modality. And as I told you, to see the biliary tree, this is the best imaging modality. You could pick up even a millimeter, 1 or 2 millimeter size stone. Definitely the stone would be very small, which has got stuck in the common duct, compressing both the obstructing both the pancreatic as well as common bile duct. So for that, I would prefer number one MRCP, and second, if we are not like patient is having some pacemaker or cochlear implant, something like that, we would rather ask for the endoscopic ultrasonography. Right now, MRI abdomen and CT abdomen does not have much role to play.
Okay, Ovik, just a point to make. You see, the question that was raised to us, this is not only a CBD stone. This patient also has a raised lipase amylase and a pain in upper abdomen. So, if you go by the American College of Gastroenterology criteria, that 2 out of the 3, there are 2 out of 3. That means we are thinking that there could have been pancreatitis, and we surgeons are very fearful of the pancreas. Bile duct stones we can deal. Pancreas is something that, we have our again a little bit of uncomfortable zone starts. So don't you think that doing a MRI of the abdomen and then combine this with an MRCP will be a better modality to diagnose the pancreatitis component.
All right. So actually, MRCP means what we do a MRI of upper abdomen in MRCP. It's not MRCP sequence, that is actually the HEST sequence, HEST, heavily titulated coronal sequence, where we can see only the biliary tree and gallbladder and pancreatic duct. Nothing else is visualized. So this is particularly, we call it MRCP sequence, but in a MRCP, in a MRI imaging, to visualize that biliary tree, we do many more sequences. Actually, we do the upper abdomen. We are not only doing this HEST sequence. So we do the coronal, I mean the axial T1, T2, and everything, all the normal sequences, standard sequences we follow. So if we call it as the MRI abdomen in combination with that HEST sequence, I'm okay with it. Definitely, if it is within 1 day of pancreatitis, or with just first approach, we are not going for a, when I don't think the contrast enhanced MRI would be a good option for him if it is not after 3 days. And if it is after 3 days, in a single shot, we can go for a contrast enhanced MRI as well to see the pancreatic necrosis and the extent of the disease.
Okay.
So basically, what it is that the MRCP in an early stage can give us an idea whether there is any stone at the in obstructed at the ampulla, isn't it? But that is actually, in the true sense of the term, in pancreatitis, you get the necrosis only after the 3rd or the 4th day, isn't it?
So on MRI or CT scan, without contrast, we could see the morphology, where like on ultrasonography, we could only see the bulky pancreas or hypoechoic pancreas. But on MRCP, MRI or CT scan, we could see the small peripancreatic collections, which may not be seen on ultrasonography. And in that case, to look for this loculated lesser sac collection, to look for the collections along the lateroconal fascia or left anteroperoneal fascia, the MRI scores better than CT scan. Only the contrast which comes in when we are suspecting we want to see the pancreatic necrosis. In that case, that is after 3 to 4 days. Before that, to see the morphology of pancreas, the peripancreatic extent of the inflammation, even the intrapancreatic any cystic lesion, the status of pancreatic duct, status of the common duct, whether there is stone present or not, MRI abdomen with MRCP would score the best.
Okay, right, fair enough. Ramanuj, I have 2 other questions. When to go for cholecystectomy in relation to gallstone size and gallbladder wall thickness?
Well, I think that as a general surgeon, the more important thing rather than the size of the gallbladder stone is to think about what is the symptoms that it produces. Number
Absolutely.
2 is that more than 3 centimeters, now if the size is more than 3 centimeters, there has been an association with gallbladder cancer, but that again comes from papers from endemic regions only. So the strength of evidence is not that strong. Cancers are associated with
middle-aged women with from the Gangetic plain with a single stone which is about 3 centimeters. That's the
exactly. So they are basically like the sun and the moon and the earth coming in the line for an eclipse. Okay, so that is the point.
Dheeraj, as usual, asked a very difficult question. Can alkaline phosphatase be normal in obstructive jaundice?
That should not be. Technically, well, that should not be usually the state of because alkaline phosphatase should rise. If you think about the pathology of an obstructive jaundice, yes, it should rise.
Guys, I just need to point out that we have another class coming up after this, so we'll actually fragment this biliary
right. Okay, and
discussion
now,
also.
So
okay, right.
what
Yes.
Avik is that as we were saying about, and this is exactly so. This is an interesting X-ray of a patient of an intestinal obstruction. I think that all of us understand that very quickly. Even in our dreams, this picture comes. You say, "Okay, guys, intestinal obstruction. Let's open up the patient." Okay, so this is an elderly gentleman who presented with an intestinal obstruction, as you can see, and he went on. Now, these are all obstructions, as you can see, of the distal end of the jejunum because you can see the concertina appearance more or the rest. The bowel loops are small bowel obstruction, because as you can see, they are situated around the midline. You can see the beautiful step ladder. These are jejunum because you can see the concertina. Okay, so this was an undergraduate thing that, but now as the patient was being planned for the operation, the patient did pass a flatus and the surgeon was now in a dilemma what to do. So what he did was that this 75-year-old gentleman underwent a CT scan of the abdomen. I think this is a non-contrast CT.
It's a
Okay,
plain CT. The surgeon
it's
did
a
a plain CT.
plain CT. Right. Okay, Avik. So quickly, this is a pretty old CT. I think around 10 years back, or around 15 years back. But again, the quality of the CT has been maintained excellent. Okay, Avik, quick diagnosis.
Yeah, just before that, I would want to see the X-ray exactly.
Exactly.
X-ray, you could see the first X-ray is the supine X-ray, and the
Okay.
second is the erect X-ray. What is the difference between these two? The supine X-ray would not have any air fluid level inside. All right. The erect X-ray, when the patient is in standing position, you see in a setting of small bowel obstruction, you see multiple air fluid levels. But in supine X-ray, you could see the extent of the disease, the extent of the small bowel which is dilated, but you are not seeing any air fluid level inside. Okay. So
Okay.
that's the basic difference. And here in CT scan, I could see a oval radiodense lesion. Yeah, exactly. And it is exactly in the right iliac fossa. There is a oval radiodense lesion, which is inside the small bowel. In single section, it is very difficult to say whether it is a jejunal portion of small bowel or a ileal portion, but the area is definitely of ileal portion. And the proximal jejunal loops are dilated. I could see the dilated jejunal loops, which are dilated. Usually, the cutoff point, this is also a theoretical thing, like in jejunal loops should be less than 3 centimeter or 3.5 centimeter, but that means 30 to 35 millimeter. Ileal loop should be in between, not more than 25 to 30 millimeter.
Okay.
Colon should,
Avik, are you saying the 369 rule? This is what we surgeons remember when we were in medical school, the 369 rule.
colon
Is it something like
cecum is 6, isn't it?
Yeah, the transverse colon was 6 and the cecum was 9.
9, exactly.
Okay,
Small bowel
right.
is 3, transverse colon is 6, and 9 is the cecum. Usually, we radiologically we say it is 7.5 or whatever, like in
Okay,
between.
okay, right.
So there is
Okay.
something radiodense lesion. You could also see the radiodensity has got a circle in circle appearance. So it is a probably stone, a calculus, gallstone, which is obstructed somewhere in the small bowel, causing a small bowel obstruction.
Excellent. So that means that, and this patient again had the earlier X-ray, which was now taken out from the bag, because the gentleman was admitted at a peripheral hospital, and then we noticed that there was an evidence of a pneumobalia. Okay, so we landed up with definitely, so this was the telltale postgraduate diagnosis of a gallstone ileus, and we got the regular stride. I think that we do have the regular stride with us. Ovik, just one question, just two questions, because I have been thinking about this for a long time. You see, when we were in medical school or when we teach our undergraduates, we say that 90% of gallbladder stones are radiolucent because they contain cholesterol, 10% are radio opaque. Now, CT scan is an X-ray. Okay, so how could you see the stone?
Yeah, see, first of all, this stone is radio opaque. It comes in that 10% category, number one.
Okay.
See, on CT scan, there is a software which is we name it Hounsfield unit, and it is nicely calibrated in a way where the air is minus 1000 Hounsfield unit, fat is, which is black. You could see the subcutaneous fat here also. Fat is minus 70 Hounsfield unit. Air is a water is a neutral structure, and it is 0 to 10 Hounsfield unit. The soft tissue in liver, spleen, soft tissue is in between the 35 to 45 Hounsfield unit. The blood is denser than that. Blood is 55 to 60 ounce per unit, and the stone, depending on the density, or it is in between the, like, it starts from 85 to around 300 to 400. Bone is the 400 to 600 plus 400 to 600 ounce per unit, and the metal is plus 3000 ounce per unit. So it is a huge range. The spectrum is huge. So on X-ray, we could say only a radio opaque shadow, radio opacity present or not, and the sensitivity is much lesser. Where in CT scan, although the gallstones are not very easily detected on CT scan, but we could see some gallstones which are radio opaque, and here it is denser stone. It definitely, a hospital unit would be more than 150 or to 200. So in that way, we can see. If you compare with the X-ray, we see more radio opaque gallstones on CT scan, but not in that way where the way we pick up it on ultrasonography or MRI.
Okay. So Avik, the second question is, why didn't we get to see the stone? It was such a large stone. What happened to the stone in this area? The stone is thinking, okay, this is the stone.
I was also thinking where it is. It has gone.
Yes, I was thinking about that. So where is the stone? Okay, so that is the reason. No, because see, in an emergency, if this patient, I will ask Dr. Bakshi now. Dr. Bakshi, sir, in this patient, this is the erect X-ray and the supine. Sir, and we are not exactly talking about gallbladder diseases in this one. Sir, would you like to do a CT scan in this patient?
Yes, don't forget he's 75 years old. And
Okay.
one of the things that I would be thinking of is mitotic lesion if he's coming. It's a problem
A
with the
sickle
gallstone.
cancer, right?
Yeah, with the gallstone ileus, inevitably these patients present with subacute obstruction, which occurs and then relieves, isn't it? But I would have actually expected that stone to have shown up with one proviso. That might be lying on the right iliac bone. So it might have been hidden by the iliac bone. So that is my concern.
Something like an appendiculolysis that happens. We usually get it shadowed by the iliac bone. Maybe that could have been a very good point. Okay, so that was a good point. Okay, to Dr. Bakshi. Sir, in this patient, you opened up the abdomen, did an enterotomy, took out the stone. Okay. Sir, important question, sir. Do you do the cholecystectomy in the same setting?
No, I don't. He's 75 years old, and I would rather have a live patient with something that I could plan for, and then plan to go in later. He's 75,
I think that these are words of wisdom, ladies and gentlemen. You see, when we were young, we think that we can conquer the world with everything. Okay, with a knife, the whole abdomen is ours. Not exactly. At this minute, these are exactly the words of wisdom. So please remember that in a gallstone ileus, think over what is blocking the tube. And usually, sir, it is my brief and small experience that once you take out the large stone, there is a small family of stones which usually accompany. If this is a papa stone, the mama stone and the baby stones usually come along. Sir, your experience.
Yes, I would agree, because that's exactly, this was 2004, my senior colleague's patient at a hospital that I worked. So that's quite some time before, 16 years actually. So he did just that. And then subsequently, the patient had investigations to find out whether he had more stones. Sure enough, he had gas in the biliary tree and in the gallbladder as well. But because by that time and follow-up, he became 76 and he had a cardiac problem and he had diabetes and chronic kidney disease. The family said he's completely asymptomatic. We don't want to do anything. That was the end of the story. But we have had occasion, Dr. Avik Bhattacharya has diagnosed cholecystocolic and cholecystoduodenal fistulas for us. Initially, we definitely did that laparoscopic at open surgery. But I think we have evolved to a stage of going in for laparoscopic management.
Exactly. Laparoscopically, right. Okay. Sir, in this one, Bulvet syndrome is a variant, you may say, of a cholecystoduodenal in which the duodenum is blocked. Can we diagnose a Bulvet syndrome by an ultrasound, because then I'm going to ask you about an MRCP and a CT scan.
Yeah, I mean, see, this is not a very frequent finding. It is a very infrequent. We very infrequently we get this type of syndromic entity, and we could
Very
try.
frequent.
Yeah, we could try on ultrasonography to see it, but I think the cross-sectional imaging would be far ahead in diagnosing this.
Okay, excellent, sir. Point well made. Because as well as Dr. Bakshi has rightly commented, that majority of the patients will not come to us directly. Believe me, they will go to an endoscopy, a gastroenterology. They are going to say that we could not negotiate the scope. Dr. Bakshi, your experience on this one?
Well, I personally haven't, which is why we promised not to take pictures of the net. So this was, my feeble attempt at drawing. So, my query is two. There are two ways that you can actually have a large stone sitting in the duodenum causing gastric outlet obstruction. It could either come from a cholecystoduodenal fistula, which is the one on the left, the stone on the left. I have personally seen people have a choledochoduodenal fistula from a stone. And I remember one patient who came to us with features of recurrent cholangitis and features of gastric outlet obstruction. We did a barium and we had a perfect MRCP demonstrated on that barium.
That means so God did the
I'll bring that X-ray when we do the next session of biliary tree radiology. I'll almost certainly bring that.
Okay, that means that God did the choledochoduostomy for you guys. So what operation did you guys do?
Well, there was a fair bit of because he came in with recurrent cholangitis, we had to disconnect with the God-given choledochoduodenostomy.
Okay, and then you went in for an end-to-side choledochoduodenostomy, or you did a hepaticojejunostomy?
I did a hepaticojejunostomy Roux-en-Y and a partial gastrectomy and a polyarp type anastomosis.
Okay, right. Avik, see, you see, when you get two surgeons, they will always talk about tubes and how to join tubes. Okay, this is exactly what happens. You see, whenever you get a surgeon, they will always, and we always have these opinions, right? Thank you. So this is all about this one. Now, so ladies and gentlemen, I think that's what we have had an interesting discussion today evening. We will end the discussion today with a very important entity today. Is now this is one of the images of a porcelain gallbladder. Okay, we have our image credits from Learning Radiology, and this is one of the very interesting diseases called as a porcelain gallbladder. It's
important to realize there are three types, Ramanuj, on an ultrasound scan. The way I think Avik can tell you that you can have a single, if you can draw it out here, you have a single line and an acoustic shadow behind this. Just a white line and an acoustic shadow.
That means that a type 1 is that if we have the gallbladder like this and we have the gallbladder like this, and if we have, that means if we have one line like this.
No, Ramanuj, you have the line on the top, which is what the ultrasonologist sees, and you have a acoustic shadow behind that. Complete.
Okay.
Correct me if I'm wrong, Avik.
Absolutely. No, so exactly.
Okay.
From the white.
That means that your shadow will be somewhat like this, I think.
The shadow
you can't see
icogenicity. The shadow should start from you cannot see the posterior wall of the gallbladder.
You cannot see the posterior wall. So it starts from that white line, Ramanuj.
Okay, that means that the white line.
You can draw the tray from the white line. Yeah. Brilliant.
Right. Okay. So if that is type 1, then
that means the entire gallbladder wall is calcified.
Right. Okay. So a type 2 then will mean that this is.
Don't draw it completely, Ramanuj. Don't draw it completely. You draw part of that anterior wall, but that's it, and part of the posterior wall. So you can now see two walls.
Okay. Right. And then what will be the shadow like?
The shadow will be, you'll see a part of the shadow out here, and part of the shadow out there. Yes.
Okay, so it will be part of shadow.
So
out there.
biconvex.
Biconvex, okay. And type 3 then will mean that
Irregular, small bits. Yes, small bits on the posterior wall, perhaps.
okay.
So you
like
have
this. So the shadow will be somewhat like this, I think.
Individual shadows, yeah.
stippled.
So stippled shadows. Okay. Just one important, just a question to both of you. Okay, so if you suspect that this is a porcelain gallbladder, I agree with the type 1 and the type 2 and the type 3. Two questions. Number one, is there any, now we all know that porcelain gallbladders are a pre-malignant condition. Okay, some people say that no, they're pre-cancerous condition, but what we all agree is that needs to be taken out. So this is something, and believe me, preferably my own personal preference is to do an open cholecystectomy, not to have a bile spill. Number two is that if you have done a laparoscopic cholecystectomy on a porcelain, it becomes very tough to hold the gallbladder. I think Dr. Bakshi, opinion, sir.
Inevitably, when that gallbladder wall is bluish because it's brittle, the moment you grab that gallbladder fundus, it ruptures. So I think I would go ahead with what Dr. Ramanuj Mukherjee is saying, and I would actually do a sort of a Lucknow approach, particularly if it's stippled. Type 2 and type 3 are the ones that are prone to cancerous. They say that the type 1, because the entire mucosa has become calcified, there's no live mucosa. So if you don't have a live mucosa, the chance of cancer is very low. With type 2 and type 3, there's a 7% chance of this being a carcinoma because of the inflammation in between.
Now, number two is that to Avik. Avik, see, whenever we surgeons get a suspected porcelain on an ultrasound, we talk to a radiologist of two things. Number one, there was an entity that we read was something called as a Limey Bile. That means that the bile contains too much amount of calcium to have an artifact shadow. So how are you so sure that this is not this? That means that I think that means that the gallbladder is filled up with too much amount of calcium excretion in this one.
True. So first of all, even if it is a type 1, although as sir also said, there is some a little bit increased chance of like mitotic conversion in type 2 and type 3, we take out all kind of porcelain gallbladder. So to me, if I diagnose a case of porcelain gallbladder, I would request my surgeon to take it out. Number one. Number two is definitely in a setting of contracted gallbladder, differentiation of the wall calcification or multiple calculi inside the gallbladder lumen is very difficult. So it is a contracted gallbladder. You could only see the wall echogenic lesion and shadow, wall echo shadow complex. When you see in a setting of chronic cholecystitis, you may find some echogenicities are seen in it is abutting the wall, and again in porcelain gallbladder, it is very confusing to differentiate that chronic cholecystitis with the type 3 porcelain gallbladder. So in that case, definitely cross-sectional imaging, particularly CT scan, holds.
That is something that was going to come.
Yes,
so
we were all going to come to that.
Always go for because as Dr. Bakshi has told, because for me a porcelain gallbladder means that that's a gallbladder cancer, and I treat it as a gallbladder cancer minus the liver. Okay, and if I feel that during the operation the liver looks, because if you do not have a frozen, that is the only thing that you can do, because you cannot have multiple chances to be taken. You get only one chance. So
would you do a segmental resection of segment 4A and 4B and 5?
Well, theoretically not, because that is the reason I will always rely on the CT scan to see the plane between the gallbladder and the liver. But to Avik, the question is that, number one is that, does all the types need a CT scan? Because we surgeons believe that all the types will need a CT scan, believe me. This is a surgeons. Whether you may argue that, okay, type 3 only needs a CT scan, we need to be safe. We cannot have the histopathology report telling that it's a gallbladder cancer, and the patient relatives tell him, doc, you did not remove the cancer. Okay, so do you think that all the things need a CT scan?
Like, see, when we are suggesting it on ultrasonography, this might be a case of porcelain gallbladder, we might be missing something as well. If it is a echogenic gallbladder having a post-acoustic shadow, we may miss the the ductal confluence, the proximal common bile duct. So in
Mhm.
that case, I think it is a wise, it would be a wise decision to go for a cross-sectional imaging CT scan in all types of porcelain gallbladder before surgery.
Okay, right. Because the next day when you talk about cancer gallbladder, we're going to talk about it. In this one, do you
Yes.
think an MRI is a better one than a CT? Though I know that calcium is better picked up on a CT scan.
Yeah.
Okay, because you see, when there is a smoke, there is a fire. When you have a calcium, we are all thinking of a cancer.
I think although the calcium per se is better visualized on CT scan, but MRI has got some beauty on its own, because if you even if you can see the calcium on MRI as well in some definite sequences, and you can see the surrounding area more clearly. But as I said, it has not got a clear-cut superiority in comparison to CT scan. MRI does not have a clear-cut superiority in diagnosing porcelain gallbladder. Number one. Number two, we can give contrast. We have to give contrast in this particular case to see any mitotic lesion already have started or not, to see the cholecystic region, the segment 4B and 5 of liver. In that case, contrast enhanced CT scan would score, I think, better than the MRI.
So next day, Avik, can we also discuss how to distinguish between cancer, because we'll be discussing cancer gallbladder, xanthorrhoeomatous cholecystitis and cancer. What do you think, Ramanuj?
Absolutely, because the next day, ladies and gentlemen, so I think that today we will be, so it's around 8 or 6 in the Indian time. So we had, so I think that we have 2 cups of coffee by this time. Okay, so I hope that you have finished your coffee also. So we have discussed about, so the common things that I think that you have seen or will be doing an operation again tomorrow or even today evening also, is about something called as the gallbladder. And we then, so today the main emphasis was on discussion about a gallbladder stone. We talked about an acute disease of the gallbladder, an acute cholecystitis. We talked about a rare disease, that was a gallstone ileus. And lastly, we talked about an uncommon disease, okay, but is in porcelain gallbladder. So the next day, ladies and gentlemen, we will be talking about a cancer of the gallbladder, which is
Ramanuj, will we
pretty
be
common.
talking of docholithiasis first and then going to cancer, perhaps?
Yes, we can, definitely. We can talk about a bile duct stone, because that holds up an gamut of this, and let us see, along with the radiologist, if we can have for a coffee, a gastroenterology, because the bile duct stones are a fight between a gastroenterologist and a surgeon. Okay,
Yes.
so over the time, we are, as surgeons, believe me, ladies and gentlemen, don't tell this to anyone. We are getting very worried that gastroenterologists are eating our food. Okay, so we are absolutely getting.
So we'll let you know when it's time for the next cup of coffee over the weekend, and we'll almost certainly post it on our site. So keep a tab on us, guys. You know, we'll let us fix up and decide.
Okay, and I think the last part of biliary radiology is something that the both of us decided that will be exclusively on bile duct injuries, because that is, again, we will have 2 gastrointestinal surgeons with me, and then we will go threadbare talking of the surgical aspect. Why does an injury happen? Not only to prevent an injury, we have had many things to prevent an injury, and then to talk about the radiology, about how to know vascular biliary injuries. So we have planned about to discuss the biliary radiology in these parts. So with this, ladies and gentlemen, thank you.
Guys, isn't it, Ramanuj?
Okay.
We are going to go into the details. If you're rushing through, you tend to skip over that. We won't do that. We've decided on this. Okay, guys?
Okay. Okay.
Right.
So
thank you, Avik. Thank you, Ramanuj.
Thank you, sir.
Thank you, Dr. Bhattacharya. Thank you, Avik. Okay.
Okay.
Right. Thank you. Bye.